Is Dr. Jack Einhaber. This is part 2 of video 1 regarding our proposed partial solution to some of the problems of healthcare systems, not just in the United States, but worldwide. So today we're going to be talking about common pitfalls in the practice of medicine which make this system so desirable, and also why electronic health records, which are very commendable, are not the whole answer. I'm going to start off with a little parable for you. Two men go fishing, and after they've been fishing a while, they're at a river it's a fast-moving river. Suddenly, they see a man in the water, arms flailing, screaming for help, obviously drowning. One man number one, let's call him, jumps into the water and saves this man, drags him out to the shore, saves his life. They take care of him, the man leaves, and they go back and fish. About an hour later, here comes another man, arms flailing, screaming for help. Fisherman number one, again, dives into the water, pulls the second man out, and saves his life. Another hour passes. They're fishing calmly. And here comes this third man. His arms are flailing. He's screaming for help. Fisherman number one, again, dives into the water, pulls him out. Fisherman number one goes back and starts fishing. But he noticed this fisherman number two isn't fishing anymore. And he said, well, why aren't you fishing? Fisherman number two says, you know what? I'm going upstream. I want to find out why all these people are coming down in the water. So, this outlines, of course, a difference in approach. One is putting out fires in a medical emergency, and the other one is emphasis on prevention. And so the system that we're going to produce, and it's going to be done in more detail in video 2, is a preventively oriented system. Now, here are some of the problems. And by the way, I'm going to mention that in my own particular case, it took 11 years before I was diagnosed properly. I had seen dozens of doctors and been in many, many difficult situations, and it took that long. And when I was diagnosed, most of the nurses, if not all of the nurses, had never heard of the particular illness that I had. A very rare, non-communicable or non-contagious orphan illness called primary sclerosing cholangitis. Now, so here are some of the pitfalls. Number one is a pitfall called anchor bias. What this means is that a lot of times the patient will come to a doctor or a group of doctors with a predetermined diagnosis. And so the tendency is, and this is all about expectations, tendency is for the doctor to try to fit in all the symptoms within that diagnosis. And if there's some symptoms that don't fit in, the tendency is to say, well, this is what's called an atypical or a not usual presentation of this particular illness or condition. Now, it's somewhat akin maybe to, in sociology, a halo effect. Somebody does something one time, and people get a general idea of this person or a general impression, and whatever the person does thereafter, the tendency is to have it fit in to this general halo or impression. You might also liken it to tunnel vision that soldiers in combat experience, and that police officers in high stress situations such as high-risk building searches encounter, where the peripheral vision is very much inhibited. Okay, now we're going to go and talk about electronic health records. There's a bunch of problems with electronic health records. Now, I believe, I agree with the current administration. I believe that electronic health records are vital to the high quality delivery of medicine, of medical care. But there's a lot of problems here. Number one, there's a lot of resistance to transitioning to these electronic health records. And I observed this firsthand. I was in one of the great hospitals here on the East Coast during a time when there was this transition. And I can just tell you that the nursing staff was, by and large, very frustrated with this. So were the doctors. I saw doctors stand in the hallway with their hands in this position, praying. I saw nurses signaling like they were tearing their hair out with this stuff. So many doctors point out that this is very expensive, and that during the 6 months or so that it takes to transition from manual to electronic records, that there is going to be a loss of productivity, a loss of revenue, and just stress and burden in general. For example, one doctor pointed out in an article that I read that if you add 1 minute to every patient that he sees per day, that's adding 40 minutes to his day. That's not to mention adding 3 minutes to every patient, because that's going to add a whole lot more. Now, some other doctors will also be faced with frustration. Their staffs will also be frustrated, and some will just have staffs who will either refuse or are just not capable of handling the transition. So they'll be faced with the problem of, what do I do? Do I get rid of my staff, or do I hire on temporary people and maybe risk having my staff feel like they're not as good as the temps that I'm hiring? That kind of thing. So there's a whole lot of problems here. And then by design, there's some 551 companies or so, or there were a couple of years ago, that were developing and producing these electronic health records. And by design, in order to maintain profits, there's no communication between most of these systems. And so the doctors, in order to communicate with another system, it requires a software patch of another $10,000 or so. So you've got all kinds of problems. So what our system is going to do is it's going to eliminate all these problems, because we will have a centralized system. And by the way, the centralized system, because of stringent security practices and requirements, we can also adapt this system to curbing nursing care abuse. Because a lot of the objections now to having cameras and other monitoring systems in nursing homes to catch abuse are based on privacy issues and civil liberties and that kind of thing. But we will, with this new system, we'll be able to address these issues. Okay, now I'm going to bring up another potential pitfall with these electronic health records. Let's say the doctors go through the transition system. Transition system has been completed, the pain of that has subsided, and the system's in place. There are no guarantees that the doctors will actually refer to the patient's electronic health records. There are no requirements for that. They're just requirements that the system is in place. Now the second thing is, even if those records are in place and the doctor refers to them, what you have, and believe me, I have had lots of experience with this, is doctors rapidly glossing over records. And I can't tell you the number of times that I've caught doctors missing important factors. And the only reason I was able to do that is because I asked for copies, or they gave me copies of the records, and I went back and I looked at them, or I looked at them while the doctor was looking at them. And I pointed out, hey, what about this, this, and this? Oh, yeah. I didn't see that. Or, oh, yeah, I saw that, but I don't think it's a problem. We'll just wait and see. That kind of thing. Now, I'd like to end off by showing you something that I'm proud of, because I'm coming up to my 15th year post-liver transplant, and the fine physicians at Columbia Presbyterian Hospital in New York City had a dinner for transplant survivors, long-term survivors. And so because of my 15 years, I received this very nice medal. So it says, well, I won't read you the part about me, but I will read you this part where it says, donate life. And this would be very nice for everybody. Okay. I thank you, and please tune in to the next video, because then we go into detail with this diagram behind me so that you'll have a better understanding of the system. And of course, I want you to notice this time that I did find my Support Our Troops lapel pin. And again, without the United States military and the allies, none of this would be possible. Okay, thank you for